Good evening, it's Dr. Soloway. If the shirt looks familiar, I already did one lecture tonight. I had such interesting stuff at the office today that I couldn't help myself, so as long as my eyes stay open, I'm going to tell you about another case today, and I'm going to teach you a little bit about Sjogrens syndrome. So today I saw a woman in her mid-20s, African American. She's had dry eyes and dry mouth for quite some time, and the only other symptom she's had, which has lasted 1 year, has been an erythematous rash that comes on with itching, and it does respond to H1 blockers. The patient was labeled as having Sjogren's about a year ago, got lost to follow-up, and came here today. She brought very recent blood work. Her rheumatoid factor was very high. Her ANA was 2560 in a speckled pattern. Her SSA and SSB were both greater than 8. Her IgG was double the upper limit of normal. It was over 3,500. In addition, she had monoclonal protein. I'll look at my notes. She had IgG kappa monoclonal protein. Apparently, the monoclonal protein was known to have occurred a year ago. All right, so clearly with dry eyes, dry mouth, and the serologies that I presented, this sounds like Sjogren's. So how do we prove a person has Sjogren's and not lupus? Well, for one, we like to use our ophthalmologist. The ophthalmologist needs to do a Schirmer's test, rose bengal staining, and fluorescein tear breakup time. So this would be one of the ways I use to diagnose Sjogren's. The next thing would be the blood work, the classic pattern being the SSA, SSB, rheumatoid factor, with or without a positive ANA. If somebody has the rheumatoid factor, SSA, SSB, this would be the typical pattern of Sjogren's. And the other helpful finding is the gamma globulinemia with the extreme elevation of IgG. Excuse me. And the last thing is typically a salivary biopsy, which is preceded by a salivary flow scan. If for whatever reason, if I have any thought that the patient does not have Sjogren's, I'll typically order a gallium scan. I'll be looking in my differential diagnosis for sarcoidosis, IgG4 related disease. There are several others in the differential diagnosis. So once we have confirmatory testing, either by a positive salivary biopsy or the ophthalmologist or the blood work, we can solidify our diagnosis by having any two of those three for a positive diagnosis. There is constantly being updated criteria, but as I tell everyone, diseases don't read textbooks, and criteria are not always correct. So you have a picture of what a Sjogren's patient is like. Clinically, they have dry mouth, they have no salivary pool in the vault, they often have erythematous eyes from dryness, and they often have glandular swelling above the neck. The other thing I wanted to mention, one of the differentiating features of Sjogren's versus lupus is the mechanism of action for thrombocytopenia. In Sjogren's, there is hypersplenism, and the big spleen eats the platelets, while in lupus, there are antibodies destroying the platelets. So this is another board question or interesting fact from Soloway's interesting cases of the day. So this particular patient who has a rash that occurs in the evening with itching sounds to me like it could be related to a lymphoma. Sjogren's, as we're aware, has about a 45 times increased risk of lymphoma than the general population. More than likely, the patient in this case will need a CAT scan of the chest, abdomen, pelvis, looking for adenopathy, and perhaps needing a biopsy leading to the diagnosis of lymphoma, and ultimately treatment with rituximab. I do not believe rituximab is typically or traditionally indicated for Sjogren's disease, but anecdotally, it absolutely works in Sjogren's disease. It works for virtually every feature of the disease, but especially in this patient with hypergammaglobulinemia, even if they do not have lymphoma, after using secretagogues, eye drops, perhaps low-dose steroids, perhaps methotrexate, pending what the symptomatology would be in an individual patient, this particular patient who has perhaps severe disease or lymphoma could end up needing rituximab. I've seen it work more than once. I've read about it. Other people have seen it work. So I want you to know that even though it may not have an official FDA indication, this is the state-of-the-art treatment for severe Sjogren's disease. And remember, while Plaquenil is used in all lupus patients, it's not needed or used properly in a Sjogren's patient. Thank you for listening, and if you have any questions, again, send them my way. Thank you.